morning, everybody. I want you to imagine you're getting ready for a really busy clinic day. And hiding behind exam room door number 3 are these adorable twins. Let's call them Mimi and Melly. Now, Mimi and Melly were born a couple weeks early, but they've been growing and developing nicely. They're just here for a routine well-child visit. While you're talking to the mom, she says, you know, I do kind of worry that Melly's vision, she doesn't seem to see as well as her sister. She doesn't track on toys. She's not interested in looking at our faces. She does like to look out the window. She likes to stare at lights. Her eyes move together, but she doesn't really even look at our faces until she hears our voice. So we'll talk about them a little bit more. But what I want to talk to you about today, using these girls as an example, is how to find a cataract, when to refer these patients to us, the ophthalmology team, and when cataracts may be indicators of systemic disease. So let's go back to looking at these girls and think about whenever patients are coming into your room, and we're going to mention some of these things over and over today, the first thing you want to do is listen to the patient or listen to the parents. Now, if you listen to the babies, they're not going to tell you too much, right? But you can look at their expressions and get an idea of what they're looking at and maybe thinking when they're interacting with you. So then we want to listen to the parents. I told you what Melly's mom said about her. But what are some other things that parents might say to you? They may say things like, Melly's mom did, this baby doesn't seem to see quite well. Or sometimes they say things like, I see something in the eye. I see a spot in there. Or I see a funny reflex. Or this eye doesn't track properly. It seems to be wandering. Or I see funny eye movements. So whenever you hear anything about the eyes or about the vision, of course that's going to draw your attention to things that you're going to do anyway. So I don't need to tell all of you, there's an AAP policy statement on red reflex testing in infants, right? But I want to encourage you to use the red reflex test not just for infants, but for any patients or kids where there's a complaint or a concern about the vision or eyes. So we can look here. Now you're going to get out your direct ophthalmoscope, right? One of my best friends. And remember to check that the filter's off. It's totally fair to turn the room lights down when you're doing this exam. Be sure you're at least arm's length away from the patient. Sometimes they need to kind of look around a little bit, because if they're looking at you, the pupils will constrict and it may be hard. But here you can see these two kids, right? What you want to find is a really bright and equal red reflex in both eyes. You don't want to see a dull reflex like you see from Melly. You don't want to see an unequal reflex. You don't want to see a yellow reflex or a white reflex. You want to find a bright and equal red reflex. So when we talk about cataract in kids, I want to just show you some, these are undilated pupils, some different examples of what you might see in the red reflex. Now, the red reflex might actually be pretty good. In the top left picture, that's really bright. And I always congratulate pediatricians who find these tiny little specks. But we still want to see those because some of these kids have asymmetric refractive error and they still have other problems, even when there's only a tiny speck. Sometimes there's an obvious white spot, like you can see in some of the other top ones on the right. The two middle pictures, these are bilateral gray or white reflexes. But they're not normal, they're not bright and red. And then to the parent's point, if sometimes the eyes are misaligned or not tracking properly, on the bottom, these two kids were actually referred because of strabismus. They weren't referred because of the red reflex, but you can see it's obviously abnormal. The bottom left picture, it's maybe not in this lighting, but the left one, the right eye is bright red reflex, the left one is grayish. And then in this child, it's a white reflex in one eye, and there actually was no red reflex, it was dark in the other. So please check for the red reflex. Now, I was supposed to have a blank slide there, but we'll leave this up. Because what I want you to think about is once you find an abnormal reflex, when do you send them? Well, we want to see all of these that are abnormal. And as you listen to many of these talks today, people are going to talk about when is it an urgent referral. So when is it an urgent referral for a cataract patient? I mean, a cataract isn't going to cause a general health problem or death, but can it affect vision and be blinding? Yes, it can. And when is that? That's particularly important for infants. Why is it important for infants? Because of deprivation amblyopia and the critical period of visual development, which is really in the first few months of life for a cataract. So if you have an infant with an abnormal reflex, if I get a call about abnormal red reflex, I usually say to families or pediatricians, do you want to come tomorrow? Right? I want to see them right away within a week. And that's because we need to plan an intervention if it's needed by the time the kids are a month to 2 months old. Even for older infants and toddlers, vision can be significantly impacted within a few weeks. So we want to see them right away. So my point about this is really that when you find an abnormal reflex, please have your office communicate clearly with the parents and with our office. So when the appointment is made, it should say abnormal red reflex, not failed vision screening. If the eye is wandering, that's an important reason for referral, but we want to know it's the abnormal red reflex. It's always frustrating if an appointment is made, but the parents don't understand and they reschedule it and they get a random scheduler who gives them an appointment 3 months later. That's too late. So just clear communication with the parents and with the referring ophthalmologist. If I know they're coming, I'm going to look for them. And if they don't show up, I'm going to call them. And if they don't come, I'm going to call you and ask you, how can I get this patient here? Okay? So we want to see them early. And then what are we going to do after we see them? You may not know they have a cataract, but we're going to say, oh, it's a cataract. So what are we going to say to you next, and what kind of things are we going to think about? So when we see them and when you see them, we should kind of categorize the patients in 2 ways. Is this a well child, or is this an unwell or dysmorphic child? Now, if it's a well child, this is usually the case for unilateral cataracts, because those are usually due to local dysgenesis within the eye, or maybe a trauma or something, right? In which case, that's another topic today. But if it's a well child, then those are often, they may be inherited or what we call idiopathic. When we see them, so you'll be paying attention when you see them, when we see them, then we may, depending on what kind of cataract we find, send back to you a list of things you might want to look for or we might want to have laboratory testing for. Now, we're thinking about 3 main categories: infectious causes, metabolic causes, and genetic causes. And so when you get a letter back, whoops, we want to just put this list here, which is not even the whole list, but these are some things that the referring or the accepting ophthalmologist may say we should check on. Fortunately, these days in Massachusetts and most states, a lot of these tests are done in the newborn screening. So if the child was born locally, probably a lot of these things have already been tested for. But maybe not if they're from out of state or out of the country. And I don't want to go through a lot of those, but I do want to talk about one cause, which you had a flash of, but in the next slide. There's one under-recognized condition. And the reason it's not recognized is because the symptoms show up not simultaneously, but sequentially, and usually to different providers. So this is where we think of the 3 players that usually don't play together, but when you find them in a patient, you should be thinking, what does this mean? Diarrhea, acquired cataract, and neurologic symptoms that in children may include behavioral problems or learning disability or autism. Okay, so what do those 3 things have in common? They might have this diagnosis: cerebrotendinous xanthomatosis, or CTX. So this is a disorder of cholesterol metabolism. And it's caused by a gene mutation. We have testing, blood testing for elevated cholesterol, and there's also genetic testing for this gene abnormality. These are often under-recognized and aren't diagnosed until early adulthood, when the neurologist starts to see these from continued neurologic deterioration. which can include seizures and peripheral neuropathies and intellectual decline and all of these sorts of things. So you might see them for diarrhea or the GI specialist. We'll see the cataract, and then later they go to neurology. But if we can think of all these things, the symptoms start early. And it's important to recognize because there's a treatment for it. And when kids get the treatment, it can reverse some of these early findings and also prevent further neurologic deterioration. I didn't used to think about this much, but it's actually not so uncommon in that group of kids who have idiopathic acquired cataracts. Now, I think here are our friends, Mimi and Melly again. So let's circle back to them just to tell the end of the story. So fortunately, when Melly came to her pediatrician, she was referred immediately. She was already 3.5 months old. We were able to do her surgery for her cataract within the next week. And she did well. She's a well child otherwise. She's shown normal growth and development. She doesn't have CTX because these were congenital, and CTX causes acquired cataract. She's, a nice young lady now who's doing well with 20/40 vision in each eye. But even though that's a good outcome, I want to point out that it's not 20/20 because of the irreversible deprivation amblyopia that already occurred. And that's why we want to see them as soon as possible and preferably operate before they're 2 months old. And fortunately, because of your hard work and good referral, we do generally have really good outcomes for cataract patients in the United States. It's not the case in many other countries or underserved areas because cataract is a leading cause of blindness in the world, even for children. So thank you for your attention to this topic. And I just want to summarize with these 3 points, take-home points, which it's not going to tell me. There it is. Please listen to the story. Find the red reflex, but refer if there's any abnormality, particularly urgently if it's young infants. And then consider systemic diagnoses for these patients.